Good morning, everyone, and welcome to the WPS webinar on evaluation and management, risk, questions, and answers. My name is Ellen Barra. I'm a specialist with our provider outreach and education team. I'm going to be your presenter today. On the line with us today is Karen Curtis, and Karen is going to be watching the chat for any questions, any comments, or things that you're placing into the chat. And that's where we do want you to place your questions. This presentation is designed as a question and answer presentation. I'm going to go over the risk element for medical decision making, and we'll do kind of a high level overview on that. And then we want to be able to take your questions. Just a couple of housekeeping things for you. On our training center webpage, we do have the training material for this presentation today, and Karen has also placed that within the chat. We are recording this, and so this will be available on our webpage under the encore presentations for about 60 to 90 days. The advantage to using that is that you don't have to go directly into YouTube. We actually have a player on our website. We know that a lot of offices kind of restrict the access to YouTube. And then we will also have the presentation on our YouTube channel, and this should be out there probably before the end of the week. You do want to submit your questions and any comments into the chat. And then we will have several opportunities for you to take a survey. If you are listening to our encore presentation on this, you also have an opportunity to take a survey. That's in the description of the video itself. We do ask that you take the time to take the survey. Number one, it's used for reporting by WPS back to CMS. The survey results are reported to our management staff, and then we use those survey results to evaluate our presentation to see if there's things that we could do better, if we did a good job, etc. The next thing that we have is a disclaimer. And we use this with each of our presentations because Medicare rules do change often. The information that we're providing you here today is as accurate as we can make it as of today. We will respond to your questions coming through the chat, and we will respond based on the facts that you provide to us within that question. Medicare rules do determine the final coverage. And of course, when we're talking about evaluation and management services, your documentation also plays a huge role in whether or not Medicare can cover the service, and then also whether or not the documentation supports the level of service that you have provided. You will see over there on the right-hand side of your screen, Medicare would ask that you do not do any screenshots, any recording. We are recording this. It will be available for you should you want to listen to it later. So what are we going to talk about today? We're going to talk about the risk element under the medical decision making. As you're aware, medical decision making is one of the two ways that you can choose your level of service for your evaluation and management services. Under the risk category, we're going to talk about some of the examples and the documentation and things that you'll need there. Now, we did receive some questions on the problem element and the data element. We won't be including those in this presentation. We did just complete a question and answer webinar on both problem and the data, and those are available within our YouTube channel and on our encore page. The documentation that we're going to be looking for in a medical record for an evaluation and management service really is the proof of thought of the practitioner. Now, the practitioner does not need to write a book, That's not what we're looking for when either we or other Medicare contractors evaluate that documentation. What we are looking for, though, is how that practitioner is evaluating the risk to the patient from the medical decision that has been made. So the next thing that we have for you here is medical necessity. This is the very first thing that we're going to be looking for. Is the service reasonable and necessary for that patient on that date? So in order for your documentation to show that, it has to show that it is reasonable and necessary for the diagnosis or treatment of an illness or injury, or to improve the functioning of a malformed body member. You can see here the three different categories of medical decision making: number and complexity of problems addressed, amount and complexity of data, and then the risk of complications and or morbidity or mortality of the patient management. So what we have here are or is the information from the American Medical Association about the risk. And you can see here it's the probability and or consequences of an event. So this is where your physician and practitioner is determining, okay, I'm going to do this for the patient, and what is the risk to the patient from that medical decision that I have made. You can also see on this slide risk includes the need to initiate testing, forego further testing, treatment, hospitalization, etc. So some examples of this: you have a patient with a stable chronic condition and you're renewing the patient's prescriptions. Well, what's the risk to that patient from this encounter? Are these new medications that could cause side effects that you need to watch for? Are these medications that the patient has been on for several years, maybe, and they're not having any difficulties with that? So your physician needs to identify what the risk is to the patient from what it is that they are determining to do. And again, that goes back to the proof of thought. What's the probability or consequences anticipated for that patient from the medical decision that was made? Would requesting, and this is a pre-submitted question that we had, would requesting a patient to go to the ER be the same as a decision regarding hospitalization? Well, again, it goes back to that proof of thought. Who's making that determination for the hospitalization? Is the physician making that during the encounter? Is the physician expecting that the ER physician is going to make that determination itself? One of the questions that we receive is, can we determine the level of risk based on what would happen if the patient was not treated? And the answer to that is no. You're going to choose your level of risk based on the treatment that you are proposing and planning for that patient. So the risk table title you can see here, it is risk of complications and or morbidity or mortality of patient management. Excuse me. So in determining the management of the patient and what is the risk to that patient, you're looking at what kind of complications could occur. Depending on the plan of care, is it such that there could be morbidity that's attached to that, or mortality that is attached to that? The items listed within the table itself are examples, and they're not absolutes. We're going to provide some scenarios for some of these examples. For an example, and this is one that people ask about quite often, ordering a prescription drug does not always mean that you have a moderate risk for the patient. And we'll talk about that as we go through. So what we have here is the picture from the table for the straightforward and the low risk. So straightforward and low is where the practitioner has identified either minimal or low risk to the patient from the treatment plan that has been chosen. This could be where your practitioner is not identifying any risk to the patient. Again, these are examples, and they're listed by the AMA as just that, examples. They're not absolutes. You want to work with your physicians and practitioners to identify the level of risk to that patient. This identifies their thought processes and what they think is going to happen with that patient. One of the pre-submitted questions that we had is an example of the patient should continue to use their CPAP machine. Well, the question was, would it only fall into straightforward or low? Well, you want to look at what's going on with that patient. If they continue to use that CPAP and it is resolving the issues that the patient has, and there isn't any risk to the patient from using that CPAP, then you would look again and choose straightforward or low. Another pre-submitted question is to whether dialysis or blood transfusions would come into the risk. Well, you want to think about whether you're ordering dialysis for the patient or a blood transfusion for the first time. As you're aware, I'm sure, dialysis can be very risky for the patient, whether you're doing the peritoneal or the hemodialysis. So, what is the risk to that patient from the decision that has been made? If the patient has been receiving this for some time, does this change the risk? Does it lower the risk because the patient has been receiving dialysis? They're not having any troubles with receiving that. There's nothing specific that you need to watch for in the patient receiving that dialysis, then that could move it into a lower level of risk. If your practitioner is not identifying the risk, then you want to query back to that physician. You want to be asking them what is their interpretation and their evaluation of the risk to that patient from the medical decision that has been made. And then, of course, the level of risk would be supported by the rest of the medical record. We have morbidity that is defined here, and this is defined by the AMA. Mortality itself is pretty easy to understand. This is whether the patient believes that the patient, or the practitioner rather, believes the patient could actually die from the problem addressed in the treatment plan chosen. Morbidity is where the patient could suffer long-lasting issues from that problem and the treatment plan that has been chosen for the patient. You'll see on here where function is limited. So think about that one for a second. If your plan of care is to amputate, and that's what the patient needed, well, their function is going to be limited. That's going to also place the patient at a higher risk. Is their quality of care going to be impaired? Is there something within that plan that's going to cause organ damage that may not be transient? That organ damage because of what needs to happen with that patient, either surgical procedure, medications, that type of thing, then those issues and things may not go away. And so that's one of the things that you'll be looking for within your documentation. So now we have moderate risk. And so let's look about these examples. We're going to talk about prescription drug management on the next slide. But we have a decision regarding minor surgery. Well, whether a surgery is major or minor is specific to that patient. This is not based on the global period that Medicare assigns to a procedure, Again, the practitioner would need to make that determination. For an example, a removal of a gallbladder for an otherwise healthy patient, the laparoscopic removal is pretty straightforward and generally is not going to be a big risk for the patient. However, you have a patient with other health issues, including possible breathing or heart issues, then this same procedure, that same gallbladder removal, could place that patient at higher risk. All procedures from an injection to an open heart surgery have risks, but what you want to identify and look for within the documentation is the risk that is applicable to that patient. A decision regarding elective major surgery. Now, this has to do more with timing. Um, an elective procedure is not going to be done right now. They're planning for this. So again, you want to identify the risk to that patient from that procedure that is being contemplated. Evidence-based calculators can be used, but they're not required for Medicare. We had a question on whether you can count as a moderate risk when the social determinants of health affect the medical decision making and also bill for the SDOH assessment. And the answer is yes, you can. And we'll cover the SDOH in more detail. We've got a webinar or an encore presentation out there that you can look at. When we're looking at social determinants of health, what your documentation needs to show is how your physician has used that information. For an example, the physician decides that the patient needs to go on insulin. Okay, and that's a good decision, but the patient is homeless. So the patient does not have a way to store that insulin since that needs to be refrigerated. So using that information, then your physicians are going to determine an additional plan of care for that patient that encompasses those social determinants of health in that plan of care. So a decision regarding surgery, we'll go back to that for a second. Does it make a difference if you do the surgery on the same day, higher or lower risk? And the answer is kind of really not. You still need to determine and evaluate that E&M for that level of risk. You also would need to use a modifier if it's appropriate in order to bill for that E&M service. Another pre-submitted question we had was, what about ordering testing? Maybe you're ordering a stress test for the patient, or you're ordering a CT scan with and without contrast. Well, again, what you want to be looking for is what is the risk to that patient. You have a patient who may have, heart issues and stuff going on, but the stress test is really not that risky for them. Whereas on the other hand, you have a patient that has a lot of additional health problems going on, and that stress test, whether doing that on a treadmill or doing that through medication management, could really be very risky for that patient. So now let's talk about prescription drug management. Now, again, the first thing you want to remember here is that it is an example. Okay, it's not an absolute. And one of the questions that we keep getting back is, my physician says continue meds. Can I always count that as prescription drug management and therefore give it a moderate level of risk? And the answer to that really is no. You want to be looking at what is the risk to the patient from those medications that have been ordered. For an example, you order an antibiotic for a patient with an upper respiratory infection. What's the risk to this patient from taking the medication? Has the patient taken the medication previously? That could be a lower risk if there were no side effects or anything from that. Do you have a patient that has bowel issues and now you need to order this antibiotic? Well, that could be more risky for the patient because of the possibilities of the diarrhea and the dehydration and everything else that could come along with ordering that antibiotic. Again, the issue is the same, the medical decision making is the same, but the risk to the patient may not be the same. It simply depends on that patient, on the encounter itself, and what your physician has documented. Another example, the patient is seeing an established patient, they're renewing their medications. Again, what's the risk to the patient? Are they medications that they have been on for a while? Are there side effects from those medications that you need to watch for? Just what is the risk to that patient? You want to go back and remember that definition of risk, the possibility or consequences of an event. So, what are the expected or possible consequences of renewing that patient's ongoing medication? What's the expected or possible consequences of ordering a new medication or changing a dosage, discontinuing a medication? When you're looking at risk, it's, what is happening with that patient and what is that patient's whole story and how does that decision affect that patient's story? One of the questions that we received is if you're going to administer a medication to the patient at the time of the service, is this prescription drug management? And the answer to that is no. That's either going to be the administration of an injection or it could be a procedure if you're injecting into the joint. It could be an infusion, whatever it is that you're doing. Now, prescription drug management generally does not include over-the-counter medications. However, it could, depending on the risk to that patient. So if your physician is asking the patient to take a much higher dose than what the over-the-counter would imply, look at the risk to that patient from taking that higher dose. If you're suggesting a patient should take an over-the-counter and there could be a possible interaction with another prescription drug that they're taking and what your physician needs to watch for, then yes, you can include that as part of your risk. Again, it goes back to that proof of thought. A pre-submitted question that we had is, what about starting a medication in the hospital and then continuing to watch that medication for efficacy during the stay? Well, again, you want to look at the risk to that patient from continuing that medication. Watching for the efficacy itself is probably not going to fall into this category. Just because they're on a medication doesn't necessarily mean that the medical decision making is a moderate risk. And here we have some information for you on those social determinants of health. Your documentation will need to include the issue from the SDOH assessment. And this is where your physician and practitioner is evaluating any screening services that you may have done for the patient, any information that the patient is giving during that encounter. We talked about the diabetes, providing nutrition information. However, the patient states they can't get to the grocery store that has the fruits and vegetables. Either they live in kind of a food desert area or they don't have transportation, and the nearest place they can go is really the convenience store down the street. Well, that's going to affect the medical decision making. And so, as your physician and practitioner makes those adjustments, then that can count as that moderate risk. And again, you can still, when you can include this as part of your choice of the level of risk, but there is a procedure code also, which is G0316, and I'll repeat that for you, G0316, that you can also bill separately for. The next thing that we have here then is a picture of the high level of risk. And again, it's high level of morbidity from additional diagnostic testing or treatment. So this can go back to, I want a CT scan with and without contrast. Well, how is that contrast material? Does that pose a risk to this patient and this particular patient's story? The first one listed there is drug therapy requiring intensive monitoring, and we're going to talk about that one on the next slide. We have a decision regarding elective major surgery, and again, like we talked about, all surgery has risk. But what is the risk from this procedure to this individual patient? Then, of course, we have decision regarding emergency major surgery. And again, that's determined by your physician whether for this patient, the surgical procedure that's going to be provided is major for them or minor for them. Decision about hospitalization or an escalation. When we're talking about hospitalization, let's go back to that ER situation. Who's really making the decision for the hospitalization? Who's making the decision that the hospital level of care needs to be escalated? This could be where you're taking them from observation to an inpatient setting, from an inpatient setting to critical care, as an example. The patient's decision not to resuscitate or to de-escalate care because of a poor prognosis. Again, you want to document that. And then a decision regarding parenteral controlled substances. We have received questions on what is a parenteral controlled substance, and these are the scheduled drugs as identified by the DEA. The link for this to identify those is contained within your resource section. A question that we receive quite often on risk is, what about a referral to the specialist? Well, again, the question goes back to, what is the risk to that patient from that decision to go to a specialist, that you want them to see a cardiologist or a pulmonologist, etc. How would you assess risk when determining a possible length of stay within the hospital? Well, the length of stay itself would not necessarily determine risk. The patient does need the hospital level of care, but why and what is happening is really that risk to the patient. Another question, patient was sent to the ER in need of higher level of care with stat, imaging, evaluation, and labs for a possible bowel obstruction. Well, what's the level of risk for that patient? That decision to send that patient to the ER could be riskier than if you gave the patient medication and sent them home to watch for a couple of days. Can both the ER physician and the hospitalist use the decision for hospital care, or is that really kind of double dipping? Well, who made the decision again to hospitalize the patient? That's the person who could use that in helping to determine their risk. Another pre-submitted question we had is, what happens if we place the patient on telemetry? Would this be an escalation of care? And probably not. They're still in the hospital. They're not moving into the critical care unit. So we talked about monitoring for toxicity. The drug itself has a potential to cause serious morbidity or death. An example could be a chemotherapy drug, although this is not exclusive. you would be performing testing on the patient to determine any adverse effects. You're not doing the monitoring to determine the efficacy. An example of this could be an INR test. Are you monitoring for the possible morbidity or death, or whether the drug is working as it should? Short term, this could be daily monitoring for any adverse effects. Excuse me, long term is at least quarterly. And you can also see here that it does have to be testing. So it's a laboratory test, a physiologic test, imaging, something along those lines. Monitoring by history or exam does not qualify for this particular example. We did have a question about blood or blood products. The questioner stated that the National Institute of Health indicated this would be similar to a drug. Now, I haven't gone to the National Institute of Health website to verify this, but if the patient is correct, then the next question becomes, what testing are you performing to monitor for that toxicity? If you're giving a blood product, for an example, are you simply watching, doing the exam, kind of watching the patient for any adverse effects, or is there testing? If there's testing, then yes, you could count that. If there's not, if you're just watching and evaluating that patient, then it would not be monitoring for toxicity. So here's the resources that we have for you. Social Security Act dealing with medical necessity is there. We have the AMA CPT changes are listed there. Controlled substances are listed there. The Internet Only Manual, and then the Evaluation and Management Service Guide. So the next thing that we're going to do is be able to take your questions. And before I open it up to Karen for questions, we do have some pre-submitted questions. And several of the pre-submitted questions gave examples of diagnoses and plans and what that level of risk would be. I can't make that determination based on the information that was provided to us. The documentation from your practitioner must indicate how they're evaluating the risk to that patient. When we review, the clinical staff will evaluate the documentation to determine what the medical record shows about the risk from the problem and the plan. Another pre-submitted question we had is, can the provider state the risk to the patient is moderate? And that's really kind of what we're looking for the practitioners to do. They're determining what that level of risk is. Just keep in mind, though, that any statements such as that must match the rest of the documentation. So now we're going to go ahead and open it up for questions. Karen?
Thanks, Ellen. The first question we got here is from Christy, and Christy says, in the risk column, the guidelines identify minor and major surgery. By definition, a procedure is less invasive than the surgery and doesn't involve an incision. Would procedures that use a natural orifice still be considered a surgery under these guidelines?
Yes, they would, because the procedure code for those would be listed within the surgery section, more than likely, of the CPT book. And it is you're going in some type of orifice, so it is an invasive procedure. So yes, you would count that as a surgery, and then your physician would determine, and documentation would show whether this is major or minor for the patient. Next question.
Our next question is from Penny, and she says, if a patient in the emergency department presents with a problem, the provider orders several labs and a scan, but then the patient leaves against medical advice. Does the provider still get credit for his thought processes?
Okay, that's a good question. The ER physician in this situation has provided an evaluation and management service. If the provider did not get to determining a plan because the patient left against medical advice, you would code that to the other two sections, the problem and the data. Keep in mind that when you're looking at choosing a level of service based on the medical decision making, you have to meet or exceed two of those three elements. So, if you have a low risk, but you have a moderate plan, you have moderate data, you can still count that as a moderate level of service. So in this situation, you really want to evaluate the documentation. It is a billable service, and then you choose your level based on your documentation. Next question.
Our next question is from Ashley, and Ashley works with a pain management practice. She asks, if a patient is on daily narcotics and the provider is refilling their script, would that count as a higher risk because of the higher risk of overdose and addiction with that medication? Or is it a lower risk since they've already been on the medication and don't have any side effects?
Okay, that's what you want to look for within your documentation. If the patient has been taking this medication, even though it's an opioid and it's a controlled substance, you want to be looking at, is the patient at risk for overdose? That's going to be, part of your depression screening, maybe. Is the patient taking this as you have instructed them? That could be a lower risk. Are you doing monitoring for toxicity? That could move it into a higher risk. So you really want to look at kind of all of those factors when you're determining the risk to that patient from that prescription medication. If the patient has, nothing else going on, the patient does not have an addictive, personality based on what you have, excuse me, what you have determined. The patient is taking them the way that you have asked them to take them. Your physician and practitioner has made a valid choice in the prescription strength and the units of service, all of that kind of stuff, then your patient could be at a lower risk. If you have patients, however, who you believe do have the addictive personalities, do have depression, do have all of these other kind of things going on that could place them at higher risk, then yes, you could move it into that category. Next question.
Our next question comes from Cora, and she says, giving an injection of Toradol in the office is risk for the injection and not for the prescription drug management. Would the risk still be moderate?
Well, if you're giving an injection within the office, that's not prescription drug management. So what you would have to look at then, and I apologize, I'm not familiar with that particular drug, but what you would have to look at is, with the injection of this drug, are you going to have to monitor the patient? Do they have to stay there for an hour or two following the injection itself because you need to watch them? If it's, a simpler injection, then the risk to that patient may not be the moderate level. It, goes back to for this patient, and I'm doing this as my plan, what's the risk to the patient from my plan? Next question.
Our next question is from Catherine, and I apologize if I mispronounce any of these medications. I was recently asked if monitoring QTC prolongation for methadone, trileptal, and tegretol, etc., be considered high risk.
Okay, so what you want to look at is how are you doing that monitoring? Because we have the information under the high risk, which is the drug therapy requiring intensive monitoring for toxicity. So that intensive monitoring could be daily, as they're starting the drug. It has to be at least quarterly, and then it has to be monitored by testing. So that's what you want to be looking for. Karen, read me the question again, but you don't have to repeat the drugs. I want to make sure I got it all.
Okay. I was recently asked if monitoring QTC prolongation would be considered high risk.
Okay, so what you want to have and what you want to look for and instruct your physicians on is what is the risk to that patient from the QT prolongation. And I apologize, I don't have information on what that is specific. But is it risky for the patient, for this patient? Because it may not be risky for somebody else, but is it for this one? Are you doing drug therapy monitoring? And if so, how are you doing that monitoring? What testing are you doing, etc.? Next question.
Our next question is from Christy, and she says, now that marijuana is legal without a prescription, would this be considered medication management in column 3? And then she also added, now I don't know if Christy, if this doesn't go along with what I just said, you'll have to let me know. She said that would be monitored by telemetry, I can't say that word, or ECG.
Okay. Um, I wouldn't think that the use of marijuana would necessarily be monitored by telemetry. However, Chrissy can let us know. So what you want to look at there, okay, marijuana is legal now. Excuse me. So what monitoring are you having to do? Um, let's go back with prescription drugs, because if your physician is monitoring this, they have determined that the patient needs to be on, or to take marijuana in order to help with a condition, then what's the risk to that patient from doing that? Does the patient have some other kind of condition going on, or some other drug that they're taking that marijuana may cause an interaction with, but the provider still wants them to be on that. Another situation you could have where it could be riskier for the patient, is the patient um, willing to um, use the marijuana within the parameters of what your physician or practitioner has determined? Or is the patient going to go in excess of that, which of course could cause additional, problems for the patient? So that's part of that proof of thought. That's part of what your physician or practitioner would be determining for that individual patient. Next question.
Okay, at this point, Ellen, I'm about to read you the last question that's come in.
Okay.
Denise asked, is the provider required to document the drug is being monitored for high toxicity?
If that's what you're doing, then including that information and why they're doing that monitoring just helps the medical reviewer understand what it is that's going on with that patient. Again, it's that patient's story. We talked earlier about you have a patient that comes in for, sinusitis, and you're giving them a prescription med. That patient's going to be at a lower risk. There's not as much work involved, I guess you could say, for that practitioner. Whereas if you have another patient coming in, and again, they have sinusitis, but They also have COPD. They also have a heart condition. You're ordering the same medication, but for that patient and within that patient's story, that's a higher level of risk. So that's what we want to see within the documentation. Again, we don't need the practitioners to write a book. This presentation today is not trying to increase the amount of documentation that they're putting within their medical record. But what we need to see, both WPS and our medical reviewers, all of the other, people who could review your medical record documentation, is we need to see concise information to support the level of service that you have provided to us. Okay, Karen, did Christy come back and ask again about that telemetry or the EKG?
It looks like maybe she said it does not the QTC, so I don't know if she was talking about
Okay,
Catherine's question.
okay, all
We
right,
have had a couple more questions come in though.
okay.
Sonia asked if a provider is evaluating one or more chronic conditions and refills meds with no charges, does stating stable on the drug count as prescription drug management? Do they have to state specific risk for each drug they refill?
They need to identify the risk, okay? Because hear what you have told me. What you've told me is that the patient has a stable chronic condition. So they are renewing medication. So that means the patient has taken these medications before. So are there identified risks to that patient from that medication that they're now on? Or that they have been on for a while. So, are you going to be watching for adverse effects? Are you going to give the patient information on identified, because again, all medications have, side effects and everything else that could happen, but are you going to give the patient instructions on particular things to watch for? That could move it into the higher level of risk. But if that's the only information that's within the medical record, we probably would not count that as a moderate level of risk. Next question.
Okay, Karen asks, if our ER provider feels a patient needs to be admitted but transfers the patient to a different facility, can that be counted in their medical decision making? Or is it only the physician that actually admits the patient that can count this?
Well, for the most part, we want the physician determining the hospitalization to identify that. But let's talk about the situation that you have. Your ER physician has determined that the patient needs additional care that cannot be provided at that particular facility. So that ER physician then is determining that the patient needs to go somewhere else. Now, whether that other facility will hospitalize them or not, your ER physician may not know that at that point. But from what you have indicated, it could indicate that the patient is at risk from the determination to transfer that patient to the additional level of care.
Okay, that's all we've got right. Oh, wait, we just got another one.
Okay.
Julie says, just to confirm, if the provider states continue current meds and does not document any risk to the patient, this would not automatically fall under prescription drug management. Am I understanding this correctly?
Yes, Julie, you are understanding that correctly. And that's why we kind of had a whole separate slide on prescription drug management. If the only thing your physician is telling us is continue current medications, That documentation does not give us any hint about the patient's risk factors and what the risk is to the patient from continuing those meds. The better way to do that is to identify the medications, and those, will be within your medical record. And then if there are concerns about a particular medication, to identify that. So let's say that the patient is on 4 different medications, but one of these medications has a side effect, and a fairly common side effect of depression or suicidal thoughts, as an example. Okay. So even in that situation, you're continuing the same meds, but now we have something that places that patient at a higher risk. So as long as that's documented, then we could count that. With the information just continue current meds, we would not be able to. Do we have anything else?
We did have another one come in.
Okay.
Lynn asks, if a consultant is provided in the ER and the provider recommends medications, but he doesn't order them, does he get credit for the prescription drug management, or does the emergency department doctor only get the credit, or do they both get credit?
Well, if it's a consultant coming in, okay, and his advice and opinion is, I think you need to do, whatever, whatever. Okay, that's part of his medical decision making. And then the ER physician is making a determination as to whether or not he or she is going to do that. And, whether the order of the medications could be valid. But again, what I want you to kind of move away from is every order of a medication does not necessarily mean a moderate level of risk. You have to evaluate what is the risk to that patient from the plan of care that your physician or practitioner has determined for that patient. Anything else?
Nope, Ellen, that's it.
Okay. We just want to thank you very much for your attendance today, for the questions and things that you have provided to us, and contributing to the discussion of risk. We're aware that risk is kind of the more difficult one because it really relies very heavily on that physician documentation. And so we appreciate your attendance in trying to understand that level of risk, and then how that can help support your level of service. So again, we ask, if you've not already taken the survey, we would ask that you do that. Again, for those listening through the encore, that is in the description of your video. So on behalf of Karen and myself, thank you so much for your attendance, and have an absolute wonderful day. You can now disconnect.